Here's the appendix. The appendix, as you can see here, is tacked up to the pelvic brim. So there's some adhesions here. That's not quite normal. So I did take it.
Okay.
Called it abnormal. And I'll write down as well, she has right-sided pain, which she does.
Okay.
Here's the stump after the appendix is gone. Here's the stump of the appendix. It puts down a triple layer of staples on each side and then cuts it. So staplers are the standard of care now. The staples are very small. They will heal into the bowel.
Okay.
They will not light up a CAT scan. They will not show up on an MRI. And they will not light up a metal detector at an airport.
Okay, good to know.
Liver edge, diaphragm, all that looks good. Page 2. This S-shaped part of the bowel is tacked up to the pelvic brim. Everybody has some of that. We release that. There's a spot here that's on the left pelvic brim or over the great vessel on the left.
Okay.
Okay, but down here, here's her left tube. Here's her left ovary. This is the S-shaped part of the bowel. This is called, this yellow part is the mesentery or fat coming off the bowel. This is totally stuck to the left ovary. And as we try to release it, there's a chocolate cyst there. You see this brown stuff coming out.
Okay.
Okay, so she did have a chocolate cyst. So she actually has at least stage 3, maybe stage 4 if you add in the adhesions, endometriosis, because of the chocolate cyst, okay?
Okay.
Again, more chocolates coming out here. So we have to release the bowel here. We identify the ureter, which is right there to make sure it's safe, but you can see how totally stuck it is. So here we're going to release all that. Here we've got the ureter here. And you can see how stuck this is, and you can see now this is the cyst of the left ovary. We called that a couple centimeters. So now here the bowel is totally freed up from the left ovary. The left ureter is totally safe. But now we're going to deal with this left cyst. So here you can see now the left ovary is freed, but there's a cyst in here. So when they've compared what is the best way to treat a chocolate cyst or endometrioma, just draining it and then leaving it, or cutting out the entire cyst wall, cutting out the entire cyst wall has been shown to be better for all the outcomes that matter to a patient,
Okay.
including pain recurrence and fertility. So we cut out the entire cyst wall, okay? The tube here is doubled back and stuck to the ovary. So we have to release that tube. We release the tube, cut out the cyst. And in doing so, we kind of split the ovary in half almost to get out the cyst, the whole cyst. See, this is kind of like one half, this is the other half of this left cyst. Sorry, of this left ovary. So we reconstruct it. We take suture and put it all back together. Page 5. There is the reconstructed left ovary. Beautiful.
So does that restore like all functionality?
It should.
Or-
It should heal.
Wow.
It should work.
That's amazing.
And it's smooth on the bottom here to try to prevent it from re-sticking to the sidewall.
Okay.
Now here's the right side. There was some disease on the on the right ovary. You see a patch of stuff there on the right ovary. So that's very suspicious for endo, but also we think that endometriomas or chocolate cysts, which you had on the left side, start with surface endo on the ovaries that become invaginated or engulfed to create an endometrioma. So we treat those surface spots on ovaries as endo, but also to prevent future endometriomas.
Okay.
So we treat that. Here we're cutting this off. Okay, we always cut around it, cut under it, scallop it off like a pancake. Here's a peritubal cyst coming off the right. So these are benign. I've always removed these. They're just little cysts hanging off the tube. We always send that off to pathology.
Okay.
And we have found endometriosis actually in peritubal cysts. So we're the first to publish on that. So we always remove them. So page 6 here, we've removed those spots off the right ovary here. Okay, so top right and left of page 5 is the before, the after is the top left of page 6.
Okay.
So now we've got the ovaries taken care of. The left ovary had some cyst that was taken out and reconstructed. Now we're going to deal with the rest of the spots of endo. So here's the uterus up here. Here's what's called the uterosacral ligament arch as a landmark. The bowel's down below here. Now you can see already There's abnormal stuff here, here, here. Okay, if you were to Google a picture of endometriosis, you would see a black powder burn or gunpowder lesion. That's the typical appearance or description. But endo can also be not black. It can be brown, red, white, blisters, retraction pockets, adhesions, peritubal cysts. So we're going to lift up behind this right ovary. So it's in this area here, okay? We see this. You see this is all retracted here. It's like a little divot. Do you see that? The ureter's here. We know the ureter's safe. There's some spots in the retracted area. So all this has to be cut out. Now this can bleed. This is part of the uterosacral ligament. It can bleed. So this whole patch was cut out. We know the ureter is back here and safe. It did bleed some, so there is some black. We have to cauterize it to keep it dry. But that whole patch is cut out, sent off to pathology. This will just heal over like a skin. Now there's still some red stuff here, and again, red is also potentially endo. So if you just burn it, not only do you likely not get the whole thing down to normal tissue, and most people would not burn in this area near the bowel, but you don't know what you just burned. So we always cut it out. And then we send it off to pathology for a tissue diagnosis. Page 7. Okay, there was another spot further back here. This is what I showed you before that we cut out. So this is an after picture of that. That was very clean, okay? So now we've got the uterus up here. This is what's called the uterosacral ligament arch. So that whole retracted area has been cut out. But now, directly behind the uterus, in between the uterus and the bowel, there's a little red patch here and a red patch here. So we're going to treat that. There's the after picture of that. Okay. And this is near the bowel, but we can make sure we get under it and make sure the bowel is safe. And then here's the after picture of that. Same thing, we know the bowel is safe. And we get the whole thing out and send it off to pathology for a tissue diagnosis. Page 8. Now you see here, there's a little retracted area here and a deep retracted area here. Do you see that?
Yes, I do.
And even further back here this way, you see some spots here. These kind of white spots. See that? So all that's suspicious for endo. Again, you don't know if you just burn it. So we cut the whole thing out. We cut out the entire pocket. We make sure we get down to the bottom of the pocket. Again, most people do not treat pockets, but we've published on that. And we have found that even if the surface of the pocket is normal, which in this case, the surface of the pocket, all this is brown, is not normal. But if you cut out the entire pocket, patients often feel better. And even if the surface is normal, 30% of patients have endo. So we cut out these pockets as a potential manifestation of endo, but also because they can be symptomatic, or at least patients can feel better when the whole pocket is cut out, which we do. So this whole pocket, both these pockets are cut out, and these white spots, the after picture of that is here.
Okay.
And again, this is part of the left uterosacral ligament, which can bleed. So there is some cautery there. But you can see, once the pocket is cut out, it actually lays flatter. I don't know if you can tell that, but she had bilateral retraction pockets. Here's the ureter on the left. We know the ureter is further back there and safe. So here's a nice overview, okay? We cut out spots from here, this whole retraction pocket here. There's a little spot here, here, this whole retraction pocket's there. And then up here, a spot back there. And then that left cyst, and then reconstructed it.
Okay.
And then release that bowel. So I won't muck it up here. Page 9, here's a repeat picture. But you see it's very clean and dry. Some char, but minimal. The right ovary here looks good. The left ovary is reconstructed. And here's the left tube. The end of it. So remember I told you it was doubled back? Like this, it was a little stuck.
Right.
So we released that, and now it's just hanging there the way it's supposed to.
Okay.
And the end of this left tube actually looks quite healthy. We looked inside the bladder for the evil twin, did not find it.
Excellent. Okay.
And then took out the appendix. So there was more there than I thought. Turns out she had a left cyst, or a left endometrioma, left chocolate cyst. So this is really stage 3 at least, endometriosis. But I would call this an optimal excision result, meaning we unstuck the bowel, cut out the left cyst, cut out whatever we could tell was endo, wherever found, in whatever form, including the cyst, the adhesions, the retraction pockets, and areas near bowel, ureter, all that was treated.
Great.
Vessels. So I would call this an optimal excision result. So most patients, when you treat the endo, they feel better. Put another way, there's no known or suspected areas of endometriosis that we didn't treat or that was left behind.
That's what I want to hear. Yeah.
And then the last part is to prevent adhesions. So we cut out, several different areas. We also had to unstick the bowel. So to prevent all that from resticking, I left in a fluid to help float the surfaces apart to try to prevent adhesions. So from animal studies, we think that adhesions, if they're going to form in the first week. So this fluid will last for a week and then it will absorb.
That's interesting.
And so it gives some hydroflotation effect, we call it, meaning it separates or floats the surfaces apart to try to prevent adhesions. In addition, suturing up this left ovary so that there's only smooth surface showing should help prevent that left ovary from sticking to the sidewall. And actually, it's kind of sitting up naturally now. So it's kind of off the sidewall. So that's good. So she might feel more bloated than usual with this fluid left in. It will absorb. But if she feels a little bloated, that's why.
Okay.
So there's a special dressing I do on the belly button, 2 down low, which is covered in skin glue to make it watertight and to prevent the stuff from leaking out. So she can just start to shower over everything tomorrow night.
Okay.
The belly button dressing comes off in 5 days. The skin glue on the ones down low, 10 days or so. And this is all written down.
Excellent. Do you believe that her predominantly right lower quadrant pain was from the abnormal looking, what was it you removed?
The appendix?
Appendix? I'm sorry.
Who knows? She had retraction pockets on both sides.
Okay.
That can be symptomatic or painful. Maybe taking out the appendix will help pain. She actually had more disease on the left. But it is true, the amount of disease and the amount of symptoms do not correlate. You don't have to have stage 4 endo to have stage 4 pain, so to speak. But also you don't have to have endo where you have the pain. So the more endo you can treat out wherever it is, the better the patient will do. But we took out that appendix. There was a retraction pocket on the right. There were some spots on the right ovary. So all that was treated. So I'm hoping that she'll feel better from all the pain.
So fertility-wise, is she...
Now, treating endo should also help fertility. Most patients, when they have endo, do have a harder time getting pregnant. Treating the endo can help improve fertility. That's been shown. So I would say the anatomy has been optimized now. Hopefully she does not need surgery again for endo. Oftentimes, though, if she's not getting pregnant when she wants to, there may be other non-surgical things to optimize to help couples get pregnant together as a couple without IVF or without bypassing things. So we do offer a clinic for that called the Restorative Fertility Clinic, with this approach of helping couples get pregnant together without IVF. So that's available, or you could find, you guys are from out of town, so you could find somebody maybe near you for that, for the non-surgical part, to optimize her chances. But the anatomy, I would say, has been optimized for fertility, and her chances of fertility now are definitely much better than they were. I'll put it that way.
And she was diagnosed with the pelvic inflammatory disease. Did you see any effects
there were adhesions there.
Okay.
Again, the bowel was stuck to this chocolate cyst. So the adhesion could be explained. I mean, infection can lead to adhesions.
Okay.
But this adhesion of the bowel to the left ovary where there was a chocolate cyst could be explained just by the endo. Endo can also cause adhesions. So I didn't see much really that could not be explained by endo, or that may be from purely the pelvic infection.
Okay.
And again, the anatomy now looks great, so hopefully it stays like that, and I think things are much better. And even though she's had surgery for endo before, just to make the point, it's not that it was all treated, all gone, and it all came back to this extent. The disease that we dealt with today was probably a disease that was always there
Right.
and never treated.
Right.
So even though she's had multiple surgeries for endo, this is probably the first time a lot of this endo was treated.
Yeah, she was surface treated basically.
Or surface treated or partially treated.
Mhm.
So, but now I think we treated whatever we could tell was endo. Again, or put another way, no suspected or known endo was left behind. So I thought it went very well, and I'm very hopeful for
yeah.
both pain and fertility. And hopefully that's all she needs.
And this tilted uterus, what's that?
By itself, it's fine. If it's
Okay.
tilted because it's stuck,
Mm-hmm.
that's one thing, but hers is not stuck, and that's fine.
Great.
So that's her copy of the pictures. It's very hard to make color copies.